Good evening, everyone. I'm chairing this session, Dr. Mohammed Lemki from Oman, and it's a pleasure to introduce Dr. William Young from the States. He's had a wealth of experience for both the adrenal and pituitary disease, working at Mayo Clinic, Rochester. He does not need much introduction, but today he will address adrenal cases, challenging cases for us to learn, and hopefully it will be a great learning experience. And you're all, after that, kindly address your questions in order to raise your level of clinical practice and understanding of the situation. Professor William Young, kindly start.
Thank you, Dr. Lemke. It's a pleasure to see you again. It's an honor to be invited to participate in your annual Congress. So I've been asked to address challenging adrenal cases. Lots of adrenal situations are challenging. I've picked two, and I'll share them with you today. With regard to this presentation, no relevant financial relationships to disclose, and I'll not be discussing off-label drug usage. The first case is a 46-year-old man with a 15-year history of hypertension, which accelerated 10 years ago, and now he has poorly controlled hypertension. He's on 3 antihypertensive drugs, a calcium channel blocker, a beta blocker, and an ACE inhibitor. But he's also taking 40 milliequivalents potassium per day, and he's not on a diuretic. So that's a huge clue right there. Beyond his hypertension and his hypokalemia, he's quite healthy. BMI is 29.2. He has no signs or symptoms of overt Cushing syndrome. He does have diabetes mellitus. He does not have diabetes mellitus or osteoporosis. He has 2 first-degree relatives who have been diagnosed with hypertension. So he probably has polygenic hypertension in the background, but with something superimposed on top of it. So here is initial electrolyte panel. Serum potassium is 3.3, and that's despite taking potassium supplement daily. His plasma aldosterone concentration measured in the morning is 26, and clearly it's inappropriate for the prevailing renin level of less than 0.6. I personally don't use an aldosterone to renin ratio. I just want to see the aldosterone above 10 nanogram per DL and the plasma renin activity less than 1. That's a positive case detection test. Because of his spontaneous hypokalemia, technically we didn't need to do confirmatory testing in his case. I got this 24-hour urine on the first day of his evaluation. His aldosterone in the urine was 28 micrograms. And you can see he was on a high sodium diet every day. I didn't salt load him. That's just what he's eating. And anything over 200 is a high sodium diet. And in that setting, if you're normal, the urinary aldosterone should be less than 12. And he was 28. So that absolutely confirms the diagnosis. So here's the adrenal CT. It's an axial image, unenhanced. He's got a 4.2 centimeter left adrenal mass that has an indeterminate attenuation at 15.6 Hounsfield units. Interestingly, the right adrenal gland appeared atrophic. You can just see part of the right adrenal gland here. You'll have to take my word for it. It also appeared atrophic on the other images. His morning cortisol was normal at 12 micrograms per DL. ACTH was undetectable, so that's interesting. DHA sulfate was low at 38 microgram per DL, normal being 48 to 244. Most common reason to measure DHA sulfate is in the workup of hirsutism in women. However, I think the best use of DHA sulfate is how I used it in this case. DHEA is made by men and women, and it's dependent on secretion of ACTH from the pituitary. When DHEA sulfate, which has a 16-hour half-life, it's very stable. When it's low, it suggests there's been chronic suppression of ACTH for whatever reason. So it's like my adrenal glycosylated hemoglobin. And I use it as a screening test for subclinical Cushing syndrome. If a patient has glucocorticoid secretory autonomy from an adrenal nodule, then you can see DHA sulfate levels slowly drop. So his is low. I think that's clinically important. I went straight to an 8 milligram overnight dexamethasone suppression test. I didn't want to deal with any false positives related to a 1 milligram overnight dex suppression test. Normal suppression is basically undetectable cortisol with this test. He's 5.9. 8 milligrams of dexamethasone is about 16 times more glucocorticoid than a person makes in a day. There's no reason to have detectable cortisol the next day. So did we do adrenal vein sampling? No. Here's the Endocrine Society diagnosis and treatment algorithm that we wrote for primary aldosteronism. I didn't put the citation here, but it's published in Journal of Clinical Endocrinology and Metabolism. And in this more recent guideline, we provided a bypass for adrenal vein sampling. And that was in a patient who has an adrenal CT. If the patient is young, less than 35 years of age, with marked primary aldo, that means spontaneous hypokalemia, plasma aldo over 30 nanograms per DL, and clear-cut unilateral adrenal adenoma, you can consider going straight to surgery. Because in that setting, you shouldn't be fooled by a non-functioning cortical adenoma because of the person's young age. And the larger the adenoma, the more severe primary aldo. So we provided that adrenal vein sampling bypass in that version of the guidelines. That's not what we're talking about with this case here, though. What we're talking about is a unilateral adrenal macroadenoma in a patient with primary aldo and subclinical Cushing's. And what I'm suggesting today is in this setting, it's also a reason to bypass adrenal vein sampling. So the patient went to laparoscopic left adrenalectomy, perioperative glucocorticoid coverage. The left adrenal weighed 36.4 grams, so it was large. Normal adrenal weight's 4 to 5 grams. And there was this 3.5 centimeter yellow cortical adenoma shown by the arrow on the bottom right. We measured the aldosterone level the day after surgery to confirm we accomplished what we hoped to, and aldosterone should be low. In this case, it was less than 4 nanogram per DL. We stopped potassium supplementation and his ACE inhibitor the day after surgery. We advised him to monitor blood pressure daily and have blood pressure meds adjusted as needed for high normal blood pressure for that first month after surgery. That first month, we don't want our patients hypotensive. We don't want them pre-renal. He went home on 20 milligrams of hydrocortisone every morning with instructions to decrease the dose to 15 milligrams in 2 weeks. So he had weekly blood potassium checks. There's a small subset of patients who will develop clinically important hyperkalemia after surgery. And if potassium's over 5.2 milliequivalents per liter, they need to go on fludrocortisone for a couple of weeks. In his case, potassium remained normal. Serum creatinine remained normal. And he had good blood pressure control on lower dosages of amlodipine and labetalol. So that's fantastic. His morning serum cortisol was obtained before his morning dose of hydrocortisone 6 weeks later, and it was greater than 10 micrograms per deciliter, telling us that his hypothalamus was making CRH, his pituitary is making ACTH, and his adrenal was making cortisol. So at that point, we stopped hydrocortisone coverage. So key points with regard to this case. First, when a patient with PA has a large adrenal adenoma, greater than a centimeter and a half, and clinicians should screen for cortisol co-secretion with baseline DHA sulfate and overnight dex suppression. That could be 1 or 2 milligrams. But again, I don't like dealing with false positives. So in this setting, with an adrenal mass, I use 8 milligrams. You can use as much as you want. What you want to know is how much true autonomy is there. So the 8 milligram overnight dex has a role to absolutely confirm glucocorticoid secretory autonomy. A normal serum cortisol concentration following 8 milligram dex would be 0, undetectable. If autonomous cortisol co-secretion is present in a patient with PA who has unilateral adrenal macroadenoma, I don't think we need to do adrenal vein sampling because this is co-secreting aldo and cortisol. Now, could it be a patient with bilateral hyperplasia and a unilateral cortisol secreting adenoma? Sure. But we don't have a good long-term medical treatment option for those patients. And whereas we have a great medical treatment option for patients with primary aldo, and that's a mineralocorticoid receptor antagonist, spironolactone or plinabulin. We don't have a good treatment option for cortisol. So patients with aldosterone cortisol secreting adenomas should have perioperative stress glucocorticoid coverage, go home on a morning dose of hydrocortisone until the HPA axis recovers. So let's move on to case 2. It's a 71-year-old man referred for evaluation of incidentally discovered right adrenal mass. CT scan was obtained 5 years previously to evaluate left lower quadrant abdominal pain, and at that time, it incidentally detected a 1.8 centimeter right adrenal mass. Subsequent CT scans showed that this mass was enlarging by an average of 4 millimeters per year. And when I saw the patient, his tumor measured 3.8 by 3.3 cm. So that's the initial CT scan. Here it is 2 years later. You can see it's slowly enlarging 4 years later and 5 years later. Hypertension, 5 years duration, was effectively treated with a calcium channel blocker, ARB, and a beta blocker. Diabetes of 2 years duration was treated with metformin and rosiglitazone. He had no signs of adrenal cortical or medullary dysfunction. He had a history of prostate cancer, treated with radiation therapy 3 years previously. BMI was normal. Blood pressure when I saw him was controlled on treatment. Sodium normal, potassium mildly elevated, creatinine normal, PSA was undetectable. Remember, he had that history of prostate cancer. Aldosterone was 8, plasma reactivity was high at 14. I get lots of email questions about this scenario. This is what renin should be. This is not a renin secreting tumor. Renin should be high if you're treating your patient with a ACE inhibitor or ARB. So we excluded primary aldo. Morning serum cortisol was 17, afternoon 7.6. DHA sulfate was not low in this case. It was normal, 105, and the 24-hour cortisol was normal. Now, for some reason, I did not do a dex suppression in this patient. And as I note here, I think I have a good reason for that. It was based on the imaging phenotype of this adrenal mass. The unenhanced CT attenuation was 39.5. Now, most of you in your imaging system at your hospital can do what I did here. You draw a region of interest around the non-cystic component of an adrenal mass, and it'll give you the unenhanced CT attenuation, 39.5. So that's lipid poor, and that is suspicious. So I screened for pheochromocytoma, and it was diagnostic. Plasma normet more than 9-fold elevated. 24-hour urine norepinephrine more than 3-fold elevated. Norepi in the urine more than 5-fold elevated. So these levels are diagnostic of pheochromocytoma. He's not taking any medication that would cause this degree of false positive testing. So to prep for surgery, I added a non-selective alpha blocker, phenoxybenzamine. I stopped his losartan, but I continued on his beta blocker and his calcium channel blocker. They're both helpful. I titrated the phenoxybenzamine for low normal systolic blood pressure. At laparoscopic right adrenalectomy, the adrenal gland weighed 19.8 grams, and the pheo measured 2.5 centimeter in maximum dimension. Stopped the phenoxybenzamine the day after surgery, and he was dismissed from the hospital that day. 5 days after surgery, blood glucose was normal without pharmacologic treatment. And we warned the patient about this because when you remove a contrarregulatory hormone like catechols, you may not need medical management for diabetes. And blood pressure was low, was normal on low dose beta blocker at that point. A year later, plasma fractionated were normal, A1C was normal with no medical therapy, and blood pressure continues to be well controlled on monotherapy. 14 years after surgery, the patient continued to do well with no evidence of recurrent FeO or diabetes. So key points. Due to the widespread use of computed abdominal imaging, at least at Mayo Clinic, 60% of our adrenal FeOs that go to surgery were discovered by accident on imaging done for other reasons. Here's just a graphic that explains that relationship. So this was published in 2019, and we're looking at 4 different series of patients on the x-axis, starting with our very first patient in 1926. Up to 1970, we had 138 patients who went to surgery. The next cohort, 106. Next cohort, 140. And the most recent cohort, and the focus of this publication, 271. Percent of patients on the y-axis. And solid bars are those patients presenting with a classic presentation with paroxysms or hypertension. So you can see in the old days, 84% of all patients presented with that classic presentation with spells and paroxysms. But look at 95 to 2004, only half. And now only a quarter present like that. What about those that are discovered by accident? Incidentally discovered, that's going to be shown in blue. And you can see it was a rare event in those first 2 series up to 1980. And usually it was on a IVP to look at the kidneys that was discovered, or it was discovered by accident during surgery for some other reason, like cholecystectomy. But with the spreading availability of cross-sectional imaging, the proportion went up to 31% in this series, and now 61%. And those that were discovered as a presentation of an abdominal mass, that's an old presentation. We just don't see that anymore. And those found because of family testing, genetic testing, that's slowly increasing. 12% in this most recent series. I think when this is looked at again in 10, 15 years, that number is going to be much higher. So lipid poor adrenal mass should be considered pheochromocytoma until proven otherwise. That's a key pearl. Although patients may not have the classic paroxysm associated with catechol hypersecretion, pheo can result in sustained hypertension and be responsible for diabetes, as it was in this patient. Although all pheos have malignant potential, they tend to grow really slow, about 3 to 5 millimeters in diameter per year. I'll show you a couple examples. This patient's going to develop a pheochromocytoma in that left adrenal gland. A year later, this is patient's getting scans for other reasons. You can see the medial portion of that adrenal is expanded. And 3 years later, there's a definite vascular nodule. And 4.5 years later, it's clearly a vascular adrenal tumor, and it is a pheochromocytoma. Here you can see that baby pheochromocytoma. It's that vascular tiny nodule seen right there. A year later, a little bigger, 2 years later, now a definite vascular nodule. 3 years later, the radiologist notices it and brings it to clinical attention. Now, these are the serial images in the patient I just shared with you today. And you can see the slow-growing lipid-poor adrenal mass. As pheos enlarge, they can get these cystic infarcted areas within them. So that was also diagnostic of pheo in this particular case. Approximately 25% of patients with pheo have diabetes mellitus, and it resolves in the majority of them after tumor resection. Well, those were the 2 challenging adrenal cases I picked for discussion today. I appreciate your attention, and I'll look forward to any questions you may have during our discussion period. Thank you.
So I'll introduce the next speaker, that is Dr. Khalid. He's from the United Arab Emirates, and he's going to talk to us about update of the acromegaly, of course, the pituitary tumor. He's working both at the Tawam and has been an active member of ACE Gulf chapter. So Dr. Khalid, the floor is yours.
Thank you, Dr. Lamki, for the introduction. Excellent. I have no disclosure for this presentation. And the main objectives actually is to review the literature and present relevant papers over the last 2 years. And I have grouped them into 4 sections. First, we'll cover epidemiology and clinical presentation. Then we'll move to some rare or uncommon comorbidities that are associated with acromegaly, and we'll focus on them. Those are the emerging comorbidities, and we'll focus on some papers discussing management. And lastly, we'll cover acromegaly and COVID. So to start with, I'll present this meta-analysis of 17 studies evaluating the epidemiology of acromegaly. And the prevalence, mean prevalence from these studies is around 59 cases per million. Most of these cases or studies were done in Europe or North America, and we had little entry in terms of data from the Gulf until early 2020, where we had 2 publications, one from Saudi Arabia, led by Dr. Al-Malki, and there was 195 cases of acromegaly over 9 centers. Similarly, we had 75 cases in 6 centers. If you look for the population of Kingdom Saudi Arabia, 35 millions, and also a third of that in our country, then this is a clear underdiagnosis. It's important to diagnose the condition early. The study highlights the reason for that. This is from a Swedish National Patient Registry. They had 603 patients over 12 years period. The mean diagnostic delay was 5.5 years. About a third did not suffer any diagnostic delay, but a quarter of the cases were diagnosed 10 years after the first comorbidity associated with acromegaly. As you would expect, the more the delay in the diagnosis, the negative consequences of the patient with increased comorbidities, but also increasing mortality if the diagnosis is not made earlier. Literature suggests that women with acromegaly are actually diagnosed at a later age compared to men with a lower IGF-1 level, perhaps because of the estrogen effect or not the so apparent somatic features compared to men. But on the good side, they are more likely to achieve a normal IGF-1 at last visit. Here is the age of the patients. Female are 3 years older compared to men at diagnosis, but they tend to have lower IGF-1 level. Patient with acromegaly, they have multiple manifestations. It's a systemic disease with somatic features, but also cardiovascular, metabolic, respiratory, and skeletal complications. In the coming slides, I'll discuss sleep apnea, vertebral fractures, and some malignancies that are associated with acromegaly. We'll start with obstructive sleep apnea. This is a meta-analysis of 24 cross-sectional studies, including 734 patients, and they looked at the prevalence of OSA and AHI in patients who are active versus inactive in terms of disease status, and then they looked at the effect of treatment. Overall, the preference of obstructive sleep apnea varied widely from 20 to 100%. Similar prevalence in patients who have active versus inactive acromegaly in terms of prevalence of obstructive sleep apnea, and also apnea-hypopnea index, except for the severe cases may be less prevalent in inactive disease. The top figure shows that there is no difference in the prevalence in the apnea-hypopnea index, but with treatment, there is some improvement in the apnea-hypopnea index. The issue with this meta-analysis, it included 24 studies, but only 8 which had a good number of patients. Heterogeneous population and limited by no longitudinal follow-up. Better study is the one that's also published in JCM, 27 patients with acromegaly, single center, but prospective design, and they had polysomnography at time 0, then 1 year later, and then 2.5 years later. Majority had macroadenoma and were pre-treated with somatostatin analog, and then later the prevalence, only 1/4 of patients did not have acromegaly related obstructive sleep apnea, but the majority had, with 1/3 having severe obstructive sleep apnea. With the years of follow-up and treatment, then there is a reduction in the rate of obstructive sleep apnea, and almost 80% did not have obstructive sleep apnea at the 2.5 years mark. And this was associated with better disease control in year 1 and year 2.5. Not only that, there was improvement in different sleep-related parameters, including respiratory disturbance index, the oxygen desaturation index, as an example. And the majority of improvement actually occurred very early in the process of treatment. Within 1 year, you get the majority of the benefit, and the IGF-1 level correlated well with a change in sleep apnea, sleep parameters. So this is a common condition, and we need to pay attention for it, screen for it, and evaluate for its improvement. Another comorbidity, which is disturbingly high in patients with acromegaly, is vertebral fracture, reported anywhere from 11% to 87%. And there are multiple risk factors for it. Disease being uncontrolled is one risk factor, but there are something other than the growth hormone and IGF-1 level, which is hypogonadism, diabetes, pre-existing vertebral fracture, and also treatment with radiotherapy. Literature suggested that BMD is not a good test to evaluate those patients because they continue to fracture with normal BMD. Maybe trabecular bone score is better. Sclerostin level was found to be similar in patients with active versus inactive acromegaly and did not predict vertebral fracture. Progression occurred even in those with controlled cases. There was a data suggesting bone active agent can be helpful in preventing vertebral fractures in active acromegaly. And in the subset of patients who were treated with pasireotide, they gained better benefit, and they had a reduction in vertebral fracture more compared to pegviscement treated patients. So there are reasons why a patient had very high vertebral fracture in some studies, why not in that study. And this paper explains some of the differences where they looked at acromegaly from 2 different centers, one from Romania and one from US. And you see in general, there are common comorbidities shared between 2 centers like hypertension, diabetes, and dyslipidemia. But there are some more frequent than other in certain centers. For example, in the center from US, obstructive sleep apnea, vertebral fracture, and colon polyps were more common compared to one from Romania. Romania had more thyroid nodules, and the reason for that is simple in this paper. If you look for it, you will find it. So they were investigating more, and they found the comorbidity. However, the very high rate of vertebral fracture is something that we don't see frequently, actually, and we think that there is something else to it. Another paper from France shed some light on this area, and they looked at 50 patients with acromegaly over a 30 years period, single center, with proper evaluation for the presence of vertebral fracture, radiological evaluation, 2 blinded experts in the field, and also a third if there was a question or concern whether this patient had vertebral fracture or not. And they found only 3 out of 50 actually having vertebral fracture. So 6%, so much lower than the reported rates in the previous studies. But what they found is that there is a significant deformities, either osteophyte disc narrowing, grade more than 2, or wedge-shaped vertebrae. And this happened in 86% of the patients, similarly in the thoracic and the lumbar spine. And they quote this, the presence of frank deformity, as possibly the reason for overestimation of vertebral fracture. So this is an important and interesting piece of information from this article, and I think it needs more study to validate it. Thyroid cancer, there is a concern about the increased risk of thyroid cancer in patients with acromegaly. We have two studies addressing this over the last 2 years. One of them is a retrospective study from a large academic center in USA, evaluating 221 patients with acromegaly. About half of them underwent ultrasound with evidence of thyroid nodules in 71 patients. 17 had FNA, and 4 of them, they had either suspicious for malignancy results or PTC. 6 underwent surgery, and the prevalence of papillary thyroid cancer in this cohort was 8.5%, which is very similar to the and the authors on this study, they do not recommend routine use of. An even better study is a study that comes from Brazil. It's a prospective single thyroid nodules, all versus the volume of thyroid was larger in patients with acromegaly. The prevalence of thyroid nodules were higher, and about 55% in both groups had indication for fine needle aspiration. None of the cases of acromegaly had thyroid cancer, compared to 2 patients in the other pituitary adenoma group. A second study suggesting no increased risk for thyroid cancer, and perhaps no need for routine ultrasound in those patients. Colorectal polyps is also frequently found in patients with acromegaly, and there is a question whether it is associated with increased risk of malignancy. This is a retrospective study from Japan evaluating 178 patients with acromegaly who underwent colonoscopy versus control. And what they found is that the proportion of patients with acromegaly with polyps were much higher in acromegaly group compared to control. The number and size of polyps were higher in the acromegaly group, but the histology in terms of high-grade adenoma or cancer did not reach statistical significance, although numerically higher. So polyps were common, but there is no statistical difference in terms of colorectal malignancy in this study. In another better designed study, multi-center study with colonoscopy done in 70 patients with acromegaly compared to 128 patients with control. Same finding, increased prevalence of polyps in patients with acromegaly, and this time both advanced adenoma and colorectal carcinoma were more common in patients with acromegaly. And in the acromegaly group, patients who had polyps, they tend to have insulin resistance more frequently compared to acromegaly group without polyps. Most of the colorectal cancer occurred in the descending colon. So this study clearly suggests increased risk for polyp and colorectal cancer, and perhaps still we continue with colonoscopy screening until we get more data. Another emerging comorbidity not frequently discussed is erectile dysfunction. The study from China reporting erectile dysfunction in about 63 patients with acromegaly. The erectile dysfunction increased significantly with age, but if you see this figure here, about 50% of patients with acromegaly who are young, 20 to 30 years, they had erectile dysfunction. And one of the main difference between the two groups who had erectile dysfunction versus no erectile dysfunction was growth hormone. So growth hormone itself, regardless of other confounding factors, is associated with increased risk for erectile dysfunction. This is not something that's frequently discussed, and I guess this is associated obviously with decreased quality of life in those patients with acromegaly. Now we move from comorbidities to diagnosis. We know that IGF-1 is the screening test, but then we go to OGTT if needed to confirm the diagnosis. OGTT, we expect that growth hormone will decrease with glucose load. However, there is a subset of patients where growth hormone will increase. And there is a study evaluating this paradoxical increase in growth hormone, which occurred in almost 1/4 of the participants from this study, which included 110 patients with acromegaly. Interestingly, those patients were older. They had higher frequency of microadenoma, less likely to be invasive. The IGF-1 is more in terms of level compared to those with no paradoxical rise in growth hormone. And they tend to have hypointense T2 and MRI with good response to therapy with somatostatin analog. So growth OGTT might give you some hint about the characteristics of patients that you will see, especially if they had a paradoxical rise in growth hormone. This is an interesting paper, which I thought will be nice to share with you. Now, obviously, we move to MRI once we suspect acromegaly. I always like to see the MRI. The panel on the picture on the left side shows macroadenoma, clear pituitary is pushed on the left, so the good chance of cure. The picture on the middle shows extension to the paracellular with invasion of the cavernous sinus, so maybe cure is an issue. The third one is one with infracellular extension, which we commonly see in patients with functioning adenoma, but also hypointense in T2, which can be helpful sign to predict response to somatostatin analog. So acromegaly guidelines suggest that surgery is the first line treatment for patients with acromegaly, and then medical therapy if surgery is not available or patient is not candidate for it. Data on surgical outcomes for acromegaly has been consistent in showing that patients with cavernous sinus invasion, higher baseline growth hormone, larger adenoma, three of those are associated with lower remission rate. There is some studies suggesting that younger age and preoperative IGF-1 can be useful as a predictor of remission after surgery. Whether sparsely granulated or densely granulated, it does not seem to help with the prediction of outcome of surgery. Always we send the cases to experienced neurosurgeon, and data is consistent about the experience of the neurosurgeon and the better outcome after surgery. If you look at medical therapy, somatostatin analogs in specific, there are 3 papers worth discussing. Predictors of somatostatin analog response: females, those who are elderly, lower IGF-1 level, T2 hypointensity, and densely granulated adenomas are likely to respond to somatostatin analog. If you look at those parameters and you select the best, perhaps the most consistent predictor is lower IGF-1 elevation. Extended dosing of lanreotide can be useful and helpful in some selected patients previously controlled with injectable somatostatin analog. So this might save some cost, and also on pandemic, this might be a good option. People can extend to 6 weeks, 8 weeks of therapy. Pasireotide has also shown better efficacy, not that much, perhaps 15 to 25% compared to the first generation somatostatin analog, but at the risk of hyperglycemia and diabetes mellitus. Now, another paper is addressing the biliary adverse events associated with somatostatin analogs. We know that somatostatin analogs inhibit cholecystokinin, which is associated with later on with impaired motility and predisposition to cholestasis and sludge. In this patient cohort, 91 patient with acromegaly treated with somatostatin analog. They had pre-treatment ultrasound and then annually. 62% of the cohort had biliary adverse events, mostly cholestasis or gallbladder stones. Again, mostly asymptomatic. 5 only were symptomatic and required surgery. 50% of those occurred within 5 years of treatment. 71% were treated with ursodeoxycholic acid, and the response was equivocal, not that great. Those who responded tend to have lower triglyceride, LDL, BMI, and lower rates of obesity as baseline. The response seems to be more in those with sludge compared to those with established gallbladder stones. Issue with this, it's a retrospective single center, no control arm, and it's unclear what was the reason for starting the ursodeoxycholic acid treatment. We move now to oral octreotide. It was tried on 56 patients controlled with injectable somatostatin analogs for 36 weeks period, and then patients were randomized to octreotide oral tablet versus placebo. And those who went to the oral arm, they maintained normal IGF-1 in 58% of the patients, and about 77 had an growth hormone less than 2.5. Obviously, it's an effective medication, and its side effect profile is similar to the injectable somatostatin analog, so might be useful for some patients. Data from pegviscement. We studied the ACRO study, which is a surveillance study of patients on pegviscement. It's an international study, and data available now for more than 10 years. At start of the program, 88% were uncontrolled. The control rate in the green here, green bars, anywhere between 62 to 80%. Similar side effect profile in terms of liver enzyme elevation, 3%. We see in this latest publication a higher frequency of enlargement of tumor, 7%. Previous literature suggests 3% only, and it's well-tolerated medication. Patients who are uncontrolled on somatostatin analogs, you can shift them. You can first try them on cabergoline. If they are uncontrolled and tumor is a concern, you could try pasireotide. If the blood glucose control is an issue, you could try pegviscement. If both are a concern, then you could use somatostatin analog and pegviscement. If uncontrolled, then you move to surgery or radiotherapy. Combination therapy is also was studied and published recently, and this is a publication from the Melmed group where they looked at patients with somatostatin analog. They were randomized to one of 3 arms, either high-dose somatostatin analog plus weekly pegviscement, or low-dose somatostatin analog and weekly pegviscement, arm B, or arm C, low-dose somatostatin analog and daily pegviscement. The arm that achieved efficacy and also reasonable cost saving is the arm B. So option of low-dose somatostatin analog plus weekly pegviscement can be used for patients. Now, radiotherapy was also an area of active research over the last 2 years. This is a meta-analysis of stereotactic radiosurgery, 20 studies, 1,500 patients with acromegaly. The remission rate, endocrine remission is 43% at 5 years, increased at 10 years to 55%. Similarly, endocrine control is much better at 10 years, and the local control, which is tumor control, is 93%. Visual toxicity is 3%, and about quarter developed hypopituitarism. Unfortunately, in this study, they do not mention exactly what's the definition of remission and control in terms of IGF-1 level and growth hormone level. Nonetheless, it's an effective therapy. Now we move to the COVID and acromegaly. There's an international survey of endocrinologists asking their opinion about how COVID affected acromegaly management. Most of them, they reported marked delay in surgical intervention. Also, it was associated with negative impact on the ability to monitor patients with labs, with imaging, or seeing the patient. However, people adapted to this new situation with increasing telephone consultation and also emails. We have recently reviewed the group in the MENA region led by Dr. Salim and the authors here, Musa Mabbar Zaina, Dr. Asha, and Salim Bashia. We summarize the effects of COVID in the pituitary gland. And if you're interested, you can see the paper. It's published in the Journal of Diabetes and Endocrine Practice. Basically, what we say that oral, if available, is an option. Need to be careful if you're using pasireotide, especially that some agent may increase the QTC interval, and the rest you can look at the publication. The positive side in the COVID, the paper published from Diego Veron group, 75% of patients controlled in 2009 pre-COVID remained under control in the COVID year as well. So control of acromegaly was not an issue in this large center, although the reduction in the clinical visit was noted in 2020, but this was compensated by telephone consultation. I think a look into the future is that machine learning and artificial intelligence will help us in early detection of patient, perhaps also utilizing some data in assessing remission rate. There are more drugs to be studied and perhaps will be soon available. Some of them I have discussed, the oral octreotide, and some I did not. This is antisense therapy. And because of time, I'll leave you with a quick summary. There is a delay in diagnosis of acromegaly, which remains an issue till now. Colonoscopy, but not thyroid ultrasound, is advised. Cavernous sinus invasion is the most important predictor of surgery outcomes. Biliary side effects are common. Stereotactic radiosurgery is effective in achieving endocrine and tumor control. And perhaps you'll see more roles for machine learning and artificial intelligence in diagnosis and remission prediction in acromegaly. And I thank you for your attention.
So thank you to both speakers. Now we'll go into the session of questions and answers. So the first question from Dr. Sajwani to Professor Young, a confirmed Cushing's condition. And basically, 24 hours urine cortisol is high, and ACTH was low, normal, with DHE was also normal. Imaging showed the pituitary microadenoma and bilateral adrenal nodules. IPSS was not available. So the question basically, he wants to know what can he do to confirm since ACTH is low, and the incidental pituitary microadenoma, is it actually the cause of the Cushing's, or it's at the adrenal nodules?
Yeah, this is a tough issue, right? We published a couple years ago a problem we had with our ACTH assay. In other words, it had problems with false positives. And we got into pickles like this one, where it was actually adrenal-dependent Cushing's, but the ACTH was mid-normal, and we were confused by that. So one of the first things I do in that setting is I contact the lab, and it's good to do serial dilutions on the ACTH, make sure it's real. Another option is send the ACTH out to a different lab. I didn't quite hear if the DHA sulfate was high or low, that can help too, because DHA sulfate's dependent on ACTH. If DHA sulfate is low, then that would suggest it's an ACTH independent situation. But yeah, you need to get this right to begin with. Usually if it's adrenal dependent, no matter what dose of dexamethasone you give, there should be no drop in urine cortisol or blood cortisol levels. Whereas if it's pituitary dependent, typically you'll get a fairly marked drop in serum cortisol, for example, with an 8 milligram overnight dexamethasone suppression test. So without knowing any more particulars, I guess those are some of my thoughts. I'd be happy to respond to an email if more details were provided.
Your opinion for medical therapy of acromegaly with succession just to avoid surgery and to maintain fertility. What is your opinion for medical therapy? If you're going to avoid surgery and maintain fertility.
Okay, I think the first line treatment for acromegaly should always be the surgery, especially in experienced center. So I won't just select medical therapy just to maintain fertility, because you could completely resect the tumor and preserve the pituitary function in many patients. Also, you could improve the pituitary function after surgery in some patients. For example, patients with acromegaly, about a third of them, they might have hyperprolactinemia, which negatively impact on the fertility as well. So you could cure that if you totally remove that tumor.
Basically, Dr. Hatsoun is asking, what is the rate of growth? Will you be able to differentiate between a pheomass, which is benign, versus malignant?
Oh, that's a tough one. So it turns out that all pheos have malignant potential. And that's why in general, we want to take them out when they're small rather than when they're large. The larger the pheo, the more likely it could be malignant and metastatic. And paragangliomas, extraadrenal catecholamine screen tumors, also have an increased risk of being malignant and metastatic. I'm not aware of anyone having data looking at growth rates and of adrenal masses that proved to be pheo and saying whether the long-term outcome was benign or the long-term outcome, the patient had metastatic disease. I'm not aware of any of those data. One would speculate that, a more aggressive pheo that grows faster would be more likely to be malignant and metastatic, but I don't have any data that proves that.
Thank you. There's another question, and that is the use of iodocholesterol for diagnosing pheo. What is your take on?
Right. So iodocholesterol scintigraphy was an old scan used for primary aldosteronism, because iodocholesterol is taken up by the adrenal cortex, and if someone's making a lot of aldosterone, that adrenal can light up. It's no longer available for use in the United States, and we never used it for pheochromocytoma. I suspect the person asking the question meant to ask about meta-iodobenzylguanidine. So I-123 MIBG is taken up by the adrenal medulla in normal people, but it's also taken up even higher and hotter in patients with catecholamine secreting tumors. So the question is, what's the role for that test? It's had a declining role over the years as CT and MR have become better. We can predict based on CT which patients actually most likely have a pheochromocytoma, and the sensitivity specificity of biochemical testing has also gotten better over the years. So although I used to order MIBG scans every week, now I might order it 3 times a year. And usually it's to look for metastatic disease. But even for that, gallium-68 dotatate PET-CT has really replaced MIBG looking for metastatic disease. So it's had a declining role over the years in localization.
Okay, there's another question, Professor Young, and that is, do you have cases of indolent pheochromocytoma where the normal urinary metanephrines remain normal, and over a period of time, it starts secreting again and becomes more apparent? This is from Dr. Shada.
Yeah, this is a good question, and that's exactly what happens. So all pheochromocytomas are pre-biochemical when they're small. In other words, the factory is not big enough. Whereas an aldosterone-producing tumor can be 4 millimeters, cause the whole syndrome. A 4 millimeter pheo, the factory is not big enough to make enough catechol to be biochemically detectable. So I showed you some of those small pheos. So biochemical tests were normal. And only once a pheo gets to be about 1.5 centimeters in diameter, it might be biochemically detectable. But even then, it may be biochemically silent. So absolutely, if you follow lipid-poor adrenal masses over time and watch them grow and get biochemistry for pheo, not that I'm advocating you do this, they will become biochemically detectable the larger the factory.
There's another case for you, sir. A case in the ICU with severe hypertension and treated with labetalol. And his urinary metanephrines were elevated, but CT scan of the abdomen and neck revealed no masses, either adrenal or otherwise. So the question is, what is your point of view? Is this a false positive result, or he should be followed and reinvestigated again?
Yeah. So there was a nice article in Journal of Clinical Endocrinology and Metabolism published earlier this year, and it highlighted something that I've personally been saying for years, and that is we don't have a good biochemical test in the ICU. All the patients in the ICU will have elevated norepinephrine and normetanephrine. They should have elevated levels. They're sick, right? They're stressed. So this article compared ICU patients to bona fide pheo patients, and there was no difference. They have the same levels, their same degree of elevation. So the test in the ICU, if you're worried about pheo, it's not biochemical. It's CT with contrast, abdomen, pelvis. 85% of catecholamine screen tumors are in the adrenal glands. 95% are between the diaphragm and the pubis. So if I have a negative CT with contrast, abdomen, pelvis, the chance my patient in the ICU has a pheo, very, very low. It's not zero. They still could have a cardiac paraganglioma, for example, but it's very low. So the patient described, it sounds like it'd be very unlikely that that patient actually has a catecholamine screen tumor.
So your second case, there was a question, does it require or warrant to do a genetic testing for your patient? This is a question put forward.
Good question. So we published a review in the New England Journal of Medicine in the summer of 2019, and there's a nice graph in there where it shows, based on the decade of life within which the tumor is discovered, the probability of finding a mutation that predisposed and caused the tumor. So in the first decade of life, for example, 90% of those kids have a germline mutation that caused their tumor. And the second decade of life, it's still high. It's like 80%. But that percentage drops. So I think the patient I presented was 60 or 70 years old. So the likelihood of a pathogenic germline mutation at that age is about 20%. So that's the discussion I have with the patient. In the United States, we need patient consent to do genetic testing. I had that discussion with that patient, and he declined. And that happens a fair amount in the US. But yes, I have the discussion of genetic testing with all patients who have pheochromocytoma or paraganglioma, but you need their consent in order to do
it. Dr. Zahrani is asking you if the use of 8 milligrams dexamethasone suppression test can give a false results if the condition is mild to moderate.
So the main reason I use the 8 milligram overnight dex suppression is to prove that the patient has adrenal autonomy. And a normal cortisol level after 8 milligrams of Dex would be undetectable, be less than 1 microgram per DL. If it's 2, 3, 4, 5 microgram per DL, that's telling me there's some autonomy there. Again, we're assuming that it's an outpatient, not in the intensive care unit and so on. Yeah, then there's autonomy. In the setting of a unilateral adrenal mass, that's telling you that that adrenal mass is autonomously producing that much cortisol. Then it's up to the clinician, assuming the patient doesn't have clinical Cushing's, it's up to the clinician to determine, is that degree of glucocorticoid autonomy important for that patient? It's as if the patient is taking 4 milligrams of prednisone every day, distributed over 24 hours a day. Is that important for that patient? Has it caused hyperglycemia, hyperlipidemia, osteoporosis, hypertension, and so on? The way I share that with the patient, and in general, especially the younger the patient, this problem's not going to go away on its own. It's only going to get worse with time. And if you have access to an expert laparoscopic adrenal surgeon, we're actually quite aggressive with our patients with adrenal-dependent subclinical Cushing syndrome.
There's another question for you. If there's any risk of doing dexamethasone suppression test in few cases?
Absolutely. And that's why I highlighted it in that second case. I said I didn't do the overnight Dex for a reason. And the reason I didn't do it, it was a lipid poor adrenal mass. It enhanced with contrast. It had that little cystic area in it. So it had the imaging phenotype of PHEO. So although we say all patients with adrenal incidentalloma should be screened for subclinical Cushing's, there's a caveat there. And that is assuming they don't have pheochromocytoma. There's a nice article out of the Netherlands published about 6 or 8 years ago in Journal Clinical Endocrinology Metabolism, where they did a literature review, and they showed that high dose steroids, whether 8 milligram of Dex or a steroid injection into a joint, can precipitate a pheochromocytoma crisis. 1 milligram overnight Dex has not been documented to cause a pheo crisis.
Question to Dr. Khalid. Last question. What is the outcome of diabetic retinopathy in patients with acromegaly? Dr. Khalid.
You spared the difficult question at the end. I don't have answer. I don't know if this is studied in the literature. No answer here.
Okay. So I'd like to thank both speakers, all the participants, and I think we can close the session now.